We have a very good return. As I told you, everybody, we are going after this session. Once we conclude this session, we are going to distribute, sorry, 1 second now. We are going to distribute 1,700 attendance certificate for this webinar for the last 10 sessions. We have 1,700 attending this webinar in the last 10 sessions. We distribute the certificates every 10 sessions. Please, you register your name, be sure, as the way you wanted to see it in the certificate. In less than a minute time, we are going to start officially the webinar. I got a message from my excellent colleague, Dr. Yasser Reda. He is telling me because the conference of Dr. Yasser Zaghloul in Emirates is just finished in the last 2 minutes, and it is a major conference, 4 days. And I personally, I have attended some part of that conference, and it is fantastic achievement and successful. And I congratulate Dr. Yasser Zaghloul for the success and the effort had been done in that conference. For us, we are so proud. Our little program tonight is under the chairman of Dr. Joe Awad. Joe Awad is, sorry for Joe, for Dr. Joe Awad. He is my colleague from Egypt. He is initially from Tanta University. He's graduated in 2008. He earned his master's degree in anesthesia and intensive care from Tanda University in 2015. First, I met Joe, of course, in Egypt before coming to Ireland, and he's here in Ireland from 2018. He earned his membership in, of the College of the Anesthesiologists, and finally he got his fellowship in anesthesia for the College of the Anesthesiologists in Ireland. Now, Joe is a big achiever. He is anesthesia and intensive care registrar in Tara University Hospital, is one of the top hospitals in Ireland, in Dublin. And he extended his work in ACLS co-director and the co-director of the Irish Heart Foundation. And he is one of the main instructor of the ACLS in Ireland. Joe, all the floor for you, and thank you very much and good luck.
Thanks a lot, Dr. Saf, for this introduction. That was so much for me. I'm delighted to be here tonight with one of the mega online anesthesiology courses, Learn, Engage, and Connect. But first, I kindly ask everyone to put his or her questions in the Q&A or question and answer chat box if there is any, and we will get back to you by the end of the presentation. Tonight, we have two interesting topics. One is for intensive care unit, ICU or intensive care, is non-invasive ventilation with helmet interface with Dr. Ranajeet Chatterjee, and the other for anesthesia, which is post-surgical chronic pain with Dr. Ahmed Abbas. But first, let me introduce to you Dr. Ranajeet Chatterjee to you. He is the Chief Medical Officer and in charge of Intensive Care Unit, Accident and Emergency of Swami Dayanat Hospital in Delhi. He's also the executive member of the Indian Society of Anesthesiology in Delhi. Dr. Ranajeet worked in intensive care for the last 17 years, and he had his training in intensive care from All India Institute of Medical Sciences in Delhi. He has been participating in many national and international conferences in anesthesia and critical care. He has papers in national and international journals and wrote numerous chapters in books related to intensive care. His area of interest are acute kidney injury and its management with continuous renal replacement therapy and sustained low efficacy daily dialysis, non-invasive ventilation with helmet, and ultrasound in critical care. Dr. Chatterjee is going to speak tonight about non-invasive ventilation with helmet interface. Off you go, Dr. Ranajeet.
Thank you, Joe, for that kind introduction, and thank you, Dr. Saad. Thank you, all the distinguished panelists who are there here. Dr. Hazem Yassin, Dr. Yasir Reza, Dr. Huda Felzi, Dr. Sazar Mozarak, Professor Sahar Mozarak. Sorry if I am spelling you wrong, and because my name is spelled wrong all the time, except Joe gave the correct spelling, actually, correct pronunciation. He told Ranajeet. Very few people in India call me Ranajeet. They were not telling Ranjeet. So thank you so much, Zoe, for this kind introduction. So my topic today is NIV with helmet as interface. And before I start my topic, I want to salute all the doctors, all the medical and the paramedical staff who have laid down their lives in fighting against COVID-19. I myself got infected twice. I lost many of my colleagues. I am deeply anguished, pained, but I'm sure that most of us are fighting it and will win this battle. And I don't have anything to disclose. And this lecture, what I'm giving today is a completely philanthropic exercise. And in this war against COVID, non-invasive ventilation has a major role to play. In fact, it is one of the instruments, one of the mechanical devices which is standing between man, between the patient and the ventilator. Millions of patients have been saved by non-invasive ventilation if they're used properly. But it will be life endangering if it is not used properly. Most of the times, non-invasive ventilation lands up into failure. And that is the main cause of worry today, exactly why NIV is failing. And what we can do to prevent this failure. And the second problem that we are facing today from non-invasive ventilation is that many of our healthcare workers are getting contaminated from the patients. We are risking our lives. NIV with the help of face masks contaminating them. So can we prevent that? Do we have any alternative? So that is the reason why this topic has been chosen. I will not give a lecture on non-invasive ventilation. I'll just give an outline. And then I'll move up to the main topic, that is how exactly to use this new interface, helmet, which is relatively new. And what are the steps that we take so that we can make helmet as an interface successful while using non-invasive ventilation. As we know, NIV is a method of mechanical ventilation aimed at augmenting spontaneous ventilation without the aid of endotracheal intubation. That is, we don't want to put the patient on a mechanical ventilation, on a ventilator. So we use some pressurized system from outside where the patient breathes and his breath is augmented. It started like this with the iron lung way back 70, 80 years before in the 1950s during the polio epidemic. And this was a negative pressure which was given with the help of this iron lung to the patients. But from negative pressure, now we have shifted to a positive pressure, non-invasive ventilation. So the advantages are many. It is not only advantageous for the doctors, but also for the patients. Now it has a flexibility in initiating and removing mechanical ventilation, as we all know. It allows intermittent application. It obviously improves patient's comfort, and it reduces the need of sedation. It keeps your oral patency intact. It preserves speech, swallowing, and expectoration, and reduces the need of vasogastric tubes. Also, it avoids the resistive work imposed by the endotracheal tube and all the complications related to endotracheal tube, whether it is an early complications like local trauma, aspiration, or hypotension, or it are late complications like injury to the hypopharynx, larynx, trachea, or ventilator-associated lung injury, hospital-acquired pneumonia, ventilator-acquired pneumonia, sinusitis, sepsis. All these complications can be avoided, and obviously it is less of cost. But as with all system, it is also not devoid of disadvantages. So a lot of disadvantages are there. It causes a slower correction of glass exchange abnormalities. Gastric distension occurs. With the facial mask, especially, there is air leakage. There is also chances of transient hypoxemia from accidental removal. Lot of eye irritation, facial skin necrosis will come to them afterwards. And obviously, the airway access and protection, you are lacking in that. So suctioning of secretions can be done. There's chances of aspiration. And in the COVID times, there's a huge chance of contamination of the healthcare workers. So this important tool is becoming a limitation for you in usage due to this property of contamination. So let us see what we can do for that. So whenever the patient who is on oxygen suddenly goes into moderate to severe respiratory distress, with the respiratory rate increasing more than 25 per minute, the accessory muscles have started working, the ABG is showing derangements, the pH is coming down, the PCO2 is going up, the PaO to FiO2 ratio is coming down, the saturation is going down. So this is the time we have to think that yes, now we have to put the patient on a non-invasive ventilation. And whether it is an acute respiratory failure, whether it is a hypercapnic acute respiratory failure, or a hypoxic acute respiratory failure, whatever it may be, they act very well, especially in acute exacerbation of COPD patients or in cardiogenic pulmonary edema patients. In slides to come, I'll give an example of a cardiogenic pulmonary edema patient, and then I'll move into the helmet ventilation. It also is quite effective in immunocompromised, especially also in patients of myasthenia gravis, in patients who are having breathing difficulties, and also patients who immediately extubate the patient, those patients from operations, sometimes you keep the patients on an IV. So it has multiple uses, and especially in COVID, as you know, both in hypoxic and hypercapnic failures, in the initial stages, it has been life-saving. But we should not use it in comatose patients or patients having cardiorespiratory arrest or having upper airways obstruction, upper GI bleed, facial surgery, trauma, etc. These are absolute contraindications. I'm not going into the details of that. We know there are different types. CPAP and BiPAP has now become a common name worldwide. Even the layman, they know what is, they could say this, my patient was on CPAP or my patient was on BiPAP. So these are all pressure preset modes. One is continuous positive airway pressure. Another is 2 levels of pressure, as we all know, that is an inspiratory positive airway pressure. And another is the expiratory positive airway pressure. When we select a ventilator, we use a pressure support PEEP mode. Here, the inspiratory positive airway pressure is PEEP plus pressure support. So if you're giving a PEEP of 10 and a pressure support of 15, that means you're giving an IPAP of 25. Whereas your EPAP or expiratory positive airway pressure will be that equal to that of PEEP. That is, if you're giving a PEEP of 10, so your expiratory positive airway pressure will be 10. So that basically is the calculation. There are also volume preset modes. We normally do not use them. And while we are setting an NIV, we have to set the NIV mode first. If you are using a BiPAP machine, you have to set the NIV mode. You have to set the IPAP. You have to set the EPAP. You have to set the respiratory rate, the inspiratory time, the RAM, the rise time. Everything has to be set. If you are setting them wrong, you might lose your patient. So that is important, how to set up an NIV machine. But we are not going to discuss this today, maybe in a different lecture, because we'll concentrate today on mainly the helmet and how to set up a helmet ventilation with the help of a non-invasive method. So whenever you are choosing non-invasive ventilation, first of all, you have to choose the machine, and then you have to choose the interface. So in a machine, either you choose a BiPAP machine or you choose a ventilator. You should be knowing that both the individual BiPAP machine or a ventilator, NIV machine or a ventilator, they have their advantages and disadvantages. Whereas you can accurately deliver FiO2 with the help of ventilator. In a BiPAP machine, it is dependent on the flow. And flow is again directly proportional to the FiO2 and inversely proportional to the respiratory positive air pressure. The more the IPAP is going up, your driving pressure is going up, more there is admixture of air and oxygen. So that you have to remember. Similarly, here the pressures which are achievable is less than the conventional ventilators in most of the BiPAP machines. Now there are advanced machines are coming, which is we are coping up with these problems. So both of them are achieved by adjusting the flow of air. Whereas in ventilators, they are with the help of pressure valves. Similarly, you have a lot of safety alarms in the ventilator and leak compensation. Again, turbine-based ventilators are very good. If you have NIV specific ventilators, leak compensation is good. Otherwise, leak compensation is compensated by increased flow in the BiPAP machines. So you must be knowing about the machines first before taking up the patient. And after selection of your machine, you select the interface. So the first interface that we select, obviously, is a face mask. So I'll go to that first. This is a face mask. What is the problem with the face mask? The first problem is every shape of face is different. The shape of face of a bearded man, shape of face of an intubulated patient, shape of face of myself, of Dr. Saad, of Dr. Ahmed, everybody's is different. So all human beings has a different shape of their face, but we have only three sizes of faces: small, middle, and large. So how can the three sizes of face mask complement all these faces? So that is the main reason of failure of NIV, because one size does not fit all. And the face mask is causing a lot of claustrophobia. See the expression in this lady. It causes air leaks. It causes lot of nasal irritation, facial irritations, nasal ulcers, nasal congestion, stomach bloating, sore nose, and whatnot. And that is the reason of this failure, from 18% to 40% failures with the help of face mask. So an excellent method, excellent device fails only for the interface. And remember, when you are using a face mask, just as a corollary, if you are using a BiPAP machine with a single tube, use a vented face mask for expiration. But if you are using a double tube from a ventilator, use a non-vented face mask. Many of us make this mistake, so I thought that I should share this with you, just to revise it again. So what we can do, there is another one that is in the form of helmet. So helmet basically is made of a plastic. And you see, we have two ports. One is the inspiratory port and the expiratory port. This is the helmet when it is fully expanded. This circular area, we can open this, give water to the patient. If the patient is asphyxiated, we can just open it so the patient can breathe. Here, there are two additional ports. If the patient is having any valves tube, you can pass through this. It will not cause any leak. Similarly, another port, we can add some extra flow through this port. You have a cushion just around the neck. Just see, this is the cushion, and this is the inflatable, that is the tube through which I have to inflate this cushion. So if you inflate the cushion, it becomes more or less watertight, airtight. And see what is happening here. We are supporting this with the help of two padded support which goes below the armpits. So this is basically a helmet. And the size of the helmet is measured from the size of the neck circumference. It comes, the measurement of the neck you have to take, and accordingly you select your helmet. Now, let us go for a small case history and then I come to this. So this is a case from my own hospital, a 25-year-old second gravida, full-time, unbooked patient. It arrived in the casualty at 7 a.m. in the morning, and she was having mild respiratory distress. She also complained of severe headache and blurred vision. Her GCS was 15 that time, pulse rate was going high, the blood pressure was very high, the respiratory rate was around 28 per minute. There was basically bed sounds, bilateral, severe S1, S2. She was just put on injection furosemide, labetalol, magnesium sulfate by the obstetricians. She was put on for delivery, and she was induced and delivered. And post-delivery, she started developing shortness of breath. And the patient was shifted 12 midnight in the ICU. And the patient was that time restless, severely dyspneic, pulse rate going up, the blood pressure was high, the respiratory rate was high, the saturation going down, there was pink from the sputum, bilateral course crepitations were there. Fortunately, the urine output was normal. The CVP was, the central line was put, it was quite high. The arterial blood pressure is going up. We put the AVP line also. We did a quick echo that is showing a stroke volume going down. The systemic vascularis is rising. The left ventricular ejection fraction was less. This ultrasound lung was done, showing the multiple B lines. This is the mild hepatomegaly and mild ascites in the patient. The PO2 ratio was going down. It's 160. The BNP was quite up. That is, the patient is in failure. The lactate level was just rising, and bilateral flappy oversities in the chest X-ray. So the diagnosis of pregnancy-induced hypertension with acute cardiogenic pulmonary edema was made. And the patient was put up on NIV with a face mask. As an interface with an EPAP of 8, IPAP of 16, we gave a ramp time of 5 minutes, the ramp of 2 centimeter water, and rise time of 100 milliseconds. The trigger inspiratory was 2 liters per minute. But the patient was completely uncomfortable in this face mask. There was substantial leak, there were asynchronies, there were wasted efforts, ineffective triggering, double triggering, and whatnot. And so, in that night, we thought, why not to give helmet a try before intubating the patient? So we started an IV support with the helmet. We choose, and with the help of a ventilator, we choose a PSV mode with a pressure support of 10, pressure support of 15, the PEEP of 10, rise time of 100 milliseconds, the inspiratory trigger of 2 liters, e-cycling of 30%. And we went on treating the hypertension. We started NTG, we started furosemide, and slowly the patient started improving. The patient accepted the helmet, started improving, the LV ejection fraction improved, the stroke volume improved, SVR came down, B line slowly disappeared, BNP came down to 150, and by day 2, the patient further improved so that we can transfer the patient day 4 to the ward. So without intubating the patient, when the face mask was a failure, we got success with the help of the helmet. So exactly as I told you, that due to the, as all one side does not fit all, that is the reason why the face mask failed, and that was the success story of the helmet. So what are the advantages? So you have a better tolerance, used for longer duration. You have a more patient autonomy. The patient can look around, the patient can speak, drink, eat, patient can cough. Even after the patient in the initial stages when the patient's respiratory system is better, he can wear glasses and read also if the patient wants. And the air leaks are rare. And then hardly I found any skin lesions. But there are disadvantages. Every machine, every interface has a disadvantage. One of the most important disadvantages, asynchrony, CO2 rebreathing, and noise. And the other two was claustrophobia. You feel a bit claustrophobic, but if you can wear the helmet yourself first and show it to the patient, see, I am wearing it, I don't feel it bad. You will also just not feel bad. Just bear with us for a few minutes or for half an hour. You will see you will improve. The patient complies. And a bit of neck irritation is there. It occurs, but it is tolerable. So these are the disadvantages. I will come exactly how to go through these disadvantages a bit later. Before that, when it started in 2003, these type of papers started coming. That is where they showed that helmet has a very high dead space volume, but it is efficient alternative to face mask during CPAP, even in severe acidosis and hypercapnia. And a lot of experiments went on in the first half of the century, where the patient was used in It was used in immunocompromised patients, after abdominal surgeries, in community-acquired pneumonia, and even in acute exacerbation of COPD, and with a variable success. Equipped with all these studies, Rodriguez in 2013 came up with this meta-analysis. And in this meta-analysis, there are 9 studies were included, which compared basically the helmet with face mask in various indications. In 8 studies, oxygenation was similar in both the groups. Outcome was similar in 6 studies. 3 studies involved acute exacerbation of COPD, and 2 studies showed lesser improvement in CO2 in the helmet. This was in 2013. The intubation rate was similar in 4, but lower in 3 studies for the helmet group. Very important. Intubation rate was lower in 3 studies in the helmet group in 2013. And the tolerance was better with helmet in 6 studies. And this meta-analysis by Liu et al. In 2016, I'll come to this later. This meta-analysis. And by 2013, when it was more or less comparable, questions started arising. The issues started coming. What are the issues? One is the CO2 rebreathing, because such a big space, patient is breathing in and out inside the helmet. Carbon dioxide is accumulating. So how to drive out this carbon dioxide and how it will be successful in COPD patients? This was one of the most important issues. The second one is the noise. Those who have used helmet, I'll show you a video, you hear the noise there. It's a huge noise that comes up to 100 decibels. And the third issue was the asynchrony. So how to basically overcome these issues and then come up with new studies? Well, that was the question. So let us take them one by one. So the first one is CO2 rebreathing. So it is bound to happen because such a big space where patient is breathing in, breathing out, CO2 is coming out. So CO2 rebreathing is bound to happen. So how can we prevent this? It's very simple. We just increase the flow of the gas, fresh gas flow. So if you use a ventilator, I've told you can control your flow, especially the turbine-based ventilators. You can go up to 250 liters per minute in turbine-based ventilators. So just increase the flow more than 50 liters per minute. And try to measure the CO2 in a quiet place inside the ventilator. So this is known as the PCO2H, which is measured just above the cushion where it is inflated, either by a mainstream or a side stream PCO2, ETCO2 monitoring, and it should be below 5 millimeter of mercury. If this is going beyond 5 millimeter of mercury, then add another 10 liters through that accessory port that I showed you. Or those who are handling your ventilators well, just go to the bias flow and change the bias flow from the normal 4 liters per minute to 10 liters per minute. Just change it. So automatically the ventilator will give 10 liters per minute flow to that extra flow to that helmet. So this will basically solve all the problems of CO2 retention and CO2 rebreathing in patients of helmet. These concepts started coming up after more or less this 2013, when we started thinking about all these things. So this was the solution to CO2 rebreathing. Though the noise, really it is associated with this very huge noise of around 100 decibels compared to 70 decibels of the face mask. This was also shown by certain papers that are mentioned here. It's very simple. Just give 2 earplugs to the patient. And you, as an intensivist inside the ICU, you try to acclimatize yourself with this noise. You have no other choice. Or if you can't, you also use a earplug. So normally we give an earplug to the patient. In fact, the earplug comes with the helmet, along with the helmet package. The company is supplying you with earplugs, knowing that it will cause a lot of noise. So the noise part is gone. The CO2 rebreathing part has been taken care of. Now the final and the most important part is the patient ventilator asynchrony. Because such a big space is definitely going to cause a lot of ineffective efforts, auto triggerings, double triggerings, late cycling in the effective triggering, and ineffective triggering along with late cycling, along with premature cycling. everything can happen in the nutshell. So how to take care of this? This was the most important deficiency of helmet. But just see how science has evolved. So there was slow pressurization and depressurization rates, inspiratory expiratory trigger delays, asynchronies, unassisted efforts, and auto. So the first paper that came out in 2009, when they're doing all these things, they just suggested you to increase the P. Take a higher PEEP, and that was the time when we started deciding, yes, let us give the helmet a chance from a ventilator rather than a BiPAP machine. So you can select PEEP at around 10, a pressure support of around 15, and half of your problem is gone. The moment the helmet becomes taut, it becomes more functional, and all these triggering problems and all these pressurization, depressurization problems starts going on. It was added on by Francisco Majoli in 2013 by excellent suggestions. Not only high P or a pressure support, but inflate your cushion. Remember, there are different types of helmets available in the world market. Some of them are without cushions, some of them are with cushions. So those who are using with cushions, they are at an advantage. Inflate that cushion. I have shown you exactly from where to inflate to up to 150 centimeter of water. And decrease your circuit length. Normally we use a 120 centimeter circuit length. Decrease it to 65 centimeters. Those 65 centimeters is a very over-enthusiastic one that has been suggested by Majoli, because if you decrease it to 65 centimeters, you just can't reach the ventilator from the patient. So I have seen it, you can keep it around 80, 85 centimeters. So shorten it and keep a fast rise time so that the helmet gets inflated very quickly. So what is fast rise time? Either you keep it around 100 milliseconds or even below that, maybe 50 milliseconds. So if you can follow these four, what is going to happen? Your pressurization rate, depressurization rate, total minute ventilation, everything is changing. You just see they're increasing, the leaks are decreasing, the inspiratory delays that has been taken care of, the unassisted efforts are more or less gone, and there is less of auto. So just by these four measures, when you are taking up a helmet, you are basically has taken care of most of your problems. And you get this type of synchronized curves. In the left one, type A curve, it is asynchronized. The dotted one is that of the helmet, and that one which is not dotted, that is of the patients. And just see when you are combining it, they are basically matching. So this matching is what is needed to avoid all the asynchronous. And when you follow all this, we get this type of paper that came out from Chicago by Dr. D.K. Patel, and they compared helmet with face mask in ARDS patients, where ARDS we normally don't use helmets, we normally don't use NIVs in the initial stages. After that, we quickly move on to ventilators. And what they found, that the treatment with helmet NIV resulted in a significant reduction in intubation rate, 61% in a facial mask group and 18% only on the helmet group. And there was also a significantly decreased reduction in 90-day mortality from 56.4% to 34.1%. So how did miracle happen? Basically, the disadvantage of the face mask is the advantage of the helmet. When you are using a face mask and you are using a BiPAP machine, if you give a end expiratory, that is your expiratory positive air pressure, EPAP, of around 6 to 8, if you exceed that, the patient will be in a lot of discomfort and there will be a lot of leaks from the face mask, and that will lead to NIV failure. Whereas in helmet, you start with a PEEP of 10 or a expiratory positive EPAP of 10. So that means you are starting with 10s, that is making the helmet more tight and making the helmet more useful. So what is a disadvantage of the face mask is a complement for the helmet. That's what is happening. And that is the reason why they found that the median PEEP in the helmet group was 3 centimeters higher than that of the face mask. And the patient discomfort and excess of air leaks was limited to the titration of P to the higher levels in the face mask. And see, why the respiratory failure was there in the face mask group? Face mask group, it was due to tachypnea, hypoxemia. Whereas the main reason of endotracheal intubation in the helmet group was neurologic failure, neither tachypnea nor hypoxemia. So we got such results in 2016. So now I come to this meta-analysis, which I told you that I'll show you later. So this meta-analysis, what they found from 11 studies and 621 patients were taken. There was lower hospital mortality in the helmet group. However, there was no significant difference in gas exchange of the ICU state. But the failure rate, see the failure rate, it was 0 in helmet and 38% in the face mask group. And in the subgroup analysis, there was decreased mortality in hypoxemic ARS patients, lower intubation rates, both hypercapnia and hypoxic patients, and there are fewer complications. And the effect of the helmet on the PCO2 was dependent on the type of ARS and the ventilation mode. Whereas the interesting part is that in NIV with face mask, 24 to 64% had to change mask. And the most common reason of the changing of mask was non-adaptation to the mask was shape of the face. So that is the problem. So that was taken care by the helmet. And in chest 2015, this beautiful study came where it was shown that there is negligible leak in the helmet if it is used with a double circuit, if it is, and especially the ventilator with filters and good seal at the neck interface. And if you are not using a helmet with a seal, the disruption may be up to 270 millimeters, that is 27 centimeters, around a feet. Whereas the corresponding leakage for the face mask with the same setup is 970 millimeters. That means around a meter. So that is the chance of dispersion of the aerosols to the healthcare workers to the face mask that compared to the helmet. And this was more, in fact, compiled in this study in 2020 by Ferrioli, where he found, just see the last line, NIV via helmet with a tight air cushion with an IPEP of 20 and an EPEP of 10, there was negligible air dispersion. Whereas with the same, without an air cushion, it was 27 centimeters as told before. And with the face mask, around 18 centimeters of IPEP and only 5 of EPEP or peak is 92 centimeters. So that amount of dispersion is coming from the face mask. Even with nasal cannula, it is 100 centimeters, with oronasal mask 40, with venturi mask 33. Everyone is having a good amount of dispersion except for the helmet. So that fear of dispersion and getting contaminated is largely eliminated if helmet is used. And Amir Fazan got so involved and so enthusiastic in the use of the helmet, they gave a COVID-19 respiratory failure management algorithm including helmet. When you get time, you go and read at your home. It is not difficult for me to explain it here because I don't have much of time also. My next speaker is waiting. So the last study that I'm going to show you is the Henny Ward study. And I congratulate the Italian workers who have used helmet during the COVID times, and they came up with this study where they compared helmet with the high flow nasal oxygen. It was a multi-center trial RCT, 4 ICUs were involved, 109 patients were there. So there was no difference in the primary outcome. Number of days free of respiratory support within 28 days after enrollment was no difference. But in the secondary output, the rate of intubation significantly lower in the helmet group, 30% or 51%. See, from 2009 to 2021, more or less the studies are showing less of endotracheal intubation and patient landing up in mechanical ventilation in the helmet group. This just cannot be a coincidence. There is a huge amount of evidence behind this. And the number of days free of invasive mechanical ventilation was significantly higher in the helmet group. So what we were giving in 2009 by the meta-analysis was same proved in 2016, and the same one showed in 2020 with the COVID patients. So inspired by this one, this study, Lavanya Munshi came out with this editorial in JAMA, and she was just short of recommending helmet to most of the patients, telling that we need some larger studies and there needs to be evaluated comparing different helmet protocols, use of sedation protocols, use of tidal volume quantification, threshold criteria for hypoxic failure to be standardized to avoid late intervention. Performance of each modality as per severity of the illness must be defined and needs time for learning. This is very important, and time to develop such evidence evaluation so that you reach a steady state where the standard care is not hampered. So this is very important. We need a lot of learning curve. We have to stand beside the patient patiently. We have to see how the helmet is working, how the patient is behaving, how the ventilator you have to change, whether the CO2 is going to change or not, how much flow you have to set up. Then only slowly you gain your confidence and you start helmet again and again, and it might be a huge success in your ICU. So with all these evidences, in 2019, when the SSC campaign gave the guidelines of COVID-19, they were not able to give any recommendation. That was quite natural. It is very difficult to give a recommendation in favor of helmet compared to face mask. But the whole thing is quite evident that as it is contaminating less and it is more successful, reducing the number of days in ventilation, reducing endotracheal intubation, why not to give helmet a chance over face mask? So this was in 2019. This is one of my patients. This is a non-COVID patient of acute hypoxic failure. See, we are using the helmet. The inspiratory and the expiratory limbs are different. You can see my resident is speaking in Hindi, and you can find the sound. See the sound. A quick sound is there. So that is the noise is very. She is responding. She's quite responding well. And see what setup I have given. I've given a setting of 50% oxygen. I'm giving a flow of 55 liters, 10 and 15. She was accumulating a bit of carbon dioxide, so giving a mode of pressure support, mode of IPAP has been given here. So this is one of the patients where we have used helmet. Achieving the saturation is going up. And this is another patient. This is basically, before showing you the video, etc., this is a helmet CPAP. Here, we are not using any ventilator or using a BiPAP machine. Here, the oxygen is coming from the wall. There are 2 ports of oxygen. And we are giving a high flow oxygen through this. This is basically a type of high flow nasal. It can be compared with high flow type of nasal cannula oxygenation, except for the fact it is given with the help of a helmet. Very interesting thing. There is a PEEP valve. I'll show you. See, my residents are very. Can you see here? This is the Venturi type of device that is being attached, and there is. Here are the 2 sources of oxygen which is coming, and it is coming to the patient. The patient is quite comfortable. Can you see the syringe here behind? This is the one with the help. We adjust the PEEP here. From 10 to 20 up to, you can 5, 10, 20, you can set it from here. I can show the video again if you want. So this is the helmet. The patient is a case of hypoxic failure, quite comfortable here in my ICU. No ventilator is attached. The oxygen is coming from the wall. There are 2 sources of oxygen, and we are adjusting the PEEP from here with the help of this one. And the company is coming up with this chart where you can adjust your flow of percentage of oxygen, and you can adjust your flow according the PEEP accordingly, and you know exactly how much flow has to be given from port A of oxygen and port B of oxygen. So this chart is given. You can select. Basically, we don't select. We basically adjust it according to our own situation and according to the patient comfort. So this is a helmet CPAP or a venti helmet to say. So the practical tips that I want to give you, my dear friends, that use the proper size of the helmet by measuring the neck circumference. Use ventilator, preferably turbine based, because that gives you a lot of flow. Use high flow, more than 50 liters per minute. Use filters, bacterial, vital, in the inspiratory and the expiratory. Select a pressure support PEEP mode. Select a PEEP of more than 10 centimeter of water and pressure support of more than 12 to 15 centimeter of water. Inspiratory trigger of around 2 liters per minute, a fast rise time of 50 milliseconds, and a TI max of around 1.5 seconds, not more than that, and expiratory sensitivity of something around 30 to 50%. Decrease the circuit length, if not to 65, but at least up to 80. Inflate the cushion of the helmet to around 1 to 2 centimeter of water, and reassure the patient, stand by the patient's side, reassure the patient, give him that confidence, yes, he is going to come out from this devastating situation, and definitely you will get a lot of success. Thank you so much for this patient hearing. This is my ICU, these are my numbers, this is my email. If you want to contact me anytime, if you're free to do that. If you have any questions, I'm here to answer those for you. Thank you so much for your patient hearing. Thank you.
Thank you so much, Dr. Ranajeet. I think we will never forget the video on the news from Italy in early COVID pandemic, and with the ICU full of patients wearing helmets. And I believe they have a big role to compensate for the overwhelmed mechanical ventilators. And who knows, helmets could be the future for non-invasive. Thank you so much for enlightening us with this new device for us, at least in Ireland. I've never seen a helmet used before in Ireland. And if you allow me, Dr. Ranajeet, to give you some questions, show you some questions from our attendees, if that's okay.
Sorry, Dr. Yusuf, can I ask a question first before your attendee? Thank you.
All right, go ahead.
Yes, Doctor.
Yeah, I have really some concern because I'm not experienced with this machine, but I have it may be a logic question, maybe not scientific, but you know that not all the science is logic and not all the logic is science. So you know that you don't think that is a very high flow is a disadvantage for the flow. This is the first one. Second one, what about the pressure on the neck and the venous return from the head and neck? It can produce any problem for the patient. In your practice, usually use a sedation or not, and what type of sedation used for this patient? And also, there is a concern if you need an urgent management of the airway, like an urgent intubation, how much time you need, and there is a disadvantage to deflate it immediately. And what do you think about that? Just I need to know from you. Thank you.
Thank you. You have a lot of questions for me. Thank you so much, Dr. Reza. Thank you. I start with the last one. That is, how much time do you need for intubation? Because when I told you that it needs eternal vigilance in an ICU. So your resident or yourself have to be standing just by the side or monitoring your patients all the time. Practice the helmet before putting it on the patient. Practice on a tool. So how quickly you can remove it. And it is not very it takes hardly 30 seconds to remove it. You need 2 persons to put it and 2 persons to remove it. It doesn't make much of time, that I can assure you. But obviously, in the initial stages, you will feel some amount of glitch. I think somebody's microphone is somebody speaking behind. Please, can you mute all of? Thank you. So that becomes a problem sometimes. Yes, you are right. That in the initial stages, you might be in a problem if you are not using it regularly. But if you practice it on a tool, on a simulator, so it hardly takes 30 seconds or even less than that to remove the helmet. Very quickly you can do it. Number one. Number two, sedation. If at all you want to give it is better to avoid sedation in this type of patients. We don't give much amount of sedation. Apprehension is more in the patients. So very low dose of midazolam, what I use in my, just to calm down the patient. I don't give, because if you give more, it will just cause respiratory depression. I don't want my patient to go into respiratory depression. I just want my patient to calm down. Even verbal assurance with the other medications going around, when the respiratory distress comes up within 15 or 20 minutes, it's like a miracle. the patient doesn't need any sedation. So if at all you are going to give any sedation, don't give much so that you depress the respiratory system of the patient. We have a lot of them. We have propofol, we have dexmedetomidine, we have fentanyl. I don't touch them. Dexmedetomidine is very good, but again, dexmedetomidine causes, the bolus dose causes a lot of hypotension. And if at all, I always avoid dexmedetomidine, the bolus dose in my patients. If at all I have to give, I give a bit of medicine. What about your third question? Yes, high flow. Yes, high flow definitely is a disadvantage, but I have seen myself taking it on myself and given the flow around 50 liters doesn't cause much of discomfort. Your apprehension is right. Maybe the patient might be having discomfort with that amount of flow. Yes, helmets are not foolproof. If those patients are having discomfort, we have to remove the helmet. We have no other choice. And I am not sure about your fourth question, which was that?
There's also a question about the pressure on the neck and the inflation for the stomach from high pressure, you know.
The pressure on the neck, this, if you have seen a helmet, you will see that this is very thin. The neck which is coming here, that is the neck cover, it's very thick. And the cushion comes here. The cushion comes here, and up to 120 centimeters of water, it does not cause much of problem or much of neck congestion. I have not seen any patient till now which has caused neck congestion and the patient has created problem. Yes, it may be a theoretical possibility. You are right. It may be a theoretical possibility. Somebody asked about the cost. The cost of the helmet in India, it is around 15,000 rupees, and you have to use it in a single patient.
Thank you, Dr. Yosef. Thank you, Dr. Engage, for and sorry for interruption.
You're welcome, Professor Reda. And we have another few questions for Dr. Ranajeet. Would you please answer these questions? Can the patient sound be heard, and can other people hear the patient sound?
Yes, the patient's sound, a very good question actually, you know, because I think the person who is asking the question, you must have seen the helmet to be used. Many of the time you cannot hear the patient, but because the sound of the helmet is so much, and the patient, what the patient is speaking, it might not come on. The patient is in respiratory distress. So if the patient is telling something you can't hear, you have a very good remedy. You just remove that circular disc and ask what exactly you are telling. So you can ask it from there. Yes, sometimes the sounds are not quite heard, and this sound is very disturbing for the patient also and for us also. You're right.
Okay, the second question, does it affect sleep or circadian rhythm?
Yes, these patients, most of these patients who are in respiratory distress, my dear, they are having sleep problems, isn't it? Because the circadian rhythm during the first few days of, not only with the helmet, but also the face mask, definitely causes a bit of sleep deprivation, a bit of change in the circadian rhythm, and a lot of ICU psychosis is created. You just take patient with this helmet or a face mask, both are claustrophobic. It will be wrong to say that a helmet is not claustrophobic. Quite claustrophobic. We just have to give assurance, but it is distressing for the patient. It causes ICU trauma, you are right. I would have loved to answer one question, you have not got it. If somebody doesn't ask, I tell it afterwards. Yes, the next one.
Okay, we have all the questions from only Mohammed Sulaiman, so we'll take them. We'll take as much as we can. He looks very interested. Is it an FDA approved or other similar authorities?
Approval, any instrument, at least in our country, when it is, we are going to use it, it has to be approved by one of the authorities in India. I don't know about the other countries, unless otherwise it is nowadays helmet is becoming slowly, it is becoming a modality which is approved by the USA also. They have their own helmet. The Europeans have their own helmet, the different companies. I believe that it is approved in most of the countries. Here, obviously, you are using it as you are using it. It's approved by our controller.
Okay, another quick question: what is about temperature or sweating? Like, does it affect I think, yeah, he said that, does it affect the temperature if there is a fever, or does it induce hyperthermia or hypothermia from the flow?
No, it doesn't. But obviously, I was expecting a question on humidification, because what type of humidification you are going to give to the helmet? Basically, you see, because that is the part where the sweating part comes, the patient gets dried up, dehydrated. Because whenever you are breathing out, we are breathing in with a cold air, and we are breathing out a hot air. There is a mixing of air inside, and that basically takes care some of the humidification part in the initial stages, which is not there in the face mask. But if at all you want to add on to the humidification, if you add certain HME filters, it also add on some amount of humidification. But the best form of humidification will be an active humidifier in this type of helmets. Most of us are using active humidifier. At all, we are giving helmet for a prolonged time. Yes, dryness is there, but it doesn't increase the temperature of the patient as such. I have not seen any patient with increased temperature from helmet. Till now, I have not seen. I was expecting a question that whether the patient can be made prone with the help of a helmet or not. Because proning is not so easy with helmet. Though certain researchers have done proning, we have not done proning. We have seen the patients are not at all comfortable with proning with the helmet. If at all you are needing proning with a helmet, I think that is the time the patient has to be put on the helmet.
Okay, so we'll take one last question. Does it increase intraocular pressure?
Still, obviously, as I've told you, that the pressure is not so much to compress the veins, so it doesn't increase intraocular pressure. If you are using, because this question comes only here when you are using a helmet with a cushion. If you are not using a cushion, it is not at all a problem. If you are using a neck cushion, yes, it might be a problem. I have not seen any patients with venous congestion or intraocular tension, increased intraocular tension.
Okay, so can I have a question myself, Dr. Ranajeet? Regarding the dead space compared to the total face mask, because that's the main problem. We're not using the total face mask because of the dead space. Compared to the total face mask, how much is the dead space, and how does it affect the gas exchange?
My whole study was basically, the whole lecture was basically on this huge dead space. Basically, how you are going to tackle this dead space, and that I've already told you that the only way of doing it is to inflate the helmet to its maximum by giving good amount of pressure, by giving good amount of flow. That is the only way we can utilize it. That dead space is basically the problem. Naturally, it will be there. Face mask doesn't have any dead space, very less compared to that of the helmet. You are correct, and that is the root of all problems of helmet. And that is the reason why these type of interventions are coming, which are nearly successful, not fully successful. Otherwise, helmet would have replaced face mask by now.
I think that's all. Thank you very much, Dr. Ranajeet. It was a very, very interesting subject, and as I said before, who knows? It could be the future for the non-invasive, and it's a good introduction for us or for the people who did not use it to have an idea from someone who had a great experience with it, like you. Thanks for having you tonight, Dr. Ranajeet.
Thank you, Joe. Thank you so much.
All right.
Thank you.
Now, our second and last lecture this night is presented by Dr. Ahmed Abbas. Dr. Ahmed Abbas is one of the highlight Egyptians in the Republic of Ireland. He is a senior registrar of anesthesia, pediatrics, intensive care, and pain medicine in Crumlin Hospital, Dublin, in Ireland. He was graduated from Mansoura University 2005. He had his master's degrees in anesthesia from Ain Shams University in 2011. Dr. Abbas has a wide experience in many tertiary hospitals in Egypt, KSA, and Ireland in the field of anesthesia, intensive care, and pain medicine. He is also a fellow of the College of Anaesthesiologists of Ireland, and he holds the Irish Diploma in Pain Medicine. His special interest is in acute and chronic pain management, for which he got his training in pain medicine in Cork University Hospital, one of the biggest university hospitals in Ireland. Dr. Ahmed is going to speak tonight about something that many of us may inadvertently underestimate, which is chronic post-surgical pain. And Dr. Ahmed promised us that he will change our practice to the better after this lecture. So off you go, Dr. Ahmed.
Thank you, Dr. Yusuf Awad, for your introduction. Thank you, Dr. Saad and the panelists for your kind invitation for this lecture series tonight. Thank you, Dr. Ranjit, as well, for this outstanding presentation. And thank you, all our audience, for being with us tonight. So today we are going to speak about a relatively new topic, which is a chronic post-surgical pain. And as Joe mentioned before, a lot of anesthetists doesn't have enough awareness about chronic post-surgical pain. And also it's an important topic for exam purposes, as it started to show up in fellowship exams recently quite a lot. So first, there is no conflict of interest to declare from my side. And the objective of this lecture tonight is to review the epidemiologic evidence of chronic post-surgical pain, describe pain mechanism of acute transformation to chronic or to chronic transition and possible impact of early intervention, and to review current evidence of preventive measures. So interest in chronic post-surgical pain has grown since the finding that more than 1/5 of the patients attending some chronic pain services describe surgery as the cause of their chronic pain. The problem is not limited to major surgeries. Even common minor procedures such as hernia repair have significant risk of chronic pain. So chronic post-surgical pain can represent significant annoyance to the patient, leading to functional limitation, psychological trauma, as well as problems for the operative team, of course, in the form of feeling of frustration and disappointment and sometimes litigation. So chronic post-surgical pain is important to have kind of awareness about it, because it increases analgesic use, have some kind of restriction to the activity of daily livings of the patient, and it reflects significant effect on the quality of life for the patient. And of course, for the health care system, it increases the utilization. So chronic post-surgical pain was first described in 1999 by Macri and Davis. And then later, they have given the first definition of chronic post-surgical pain by Macri in 2001. And he described it as a pain that developed after surgical intervention and lasts at least 2 months. Other cause of pain has to be excluded, in particular, pain from a condition preceding the surgery. And this was in 2001, and it was published in this article. Soon after, an updated definition of chronic post-surgical pain followed that. And it was proposed by Werner and Kongsgaard in 2014. And they give working diagnosis for chronic post-surgical pain as pain persisting more than 3 months. If you can remember, the first definition was only 2 months. Now it became 3 months after the surgery. Pain not present before surgery, or that has different characteristic or increased intensity from preoperative pain, and it should be localized to the surgical site or any referred area. And of course, other possible causes of pain should be excluded, for example, cancer recurrence and infection. So how about the incidence of chronic post-surgical pain? If you can see from this table, there's a lot of surgery which can cause chronic post-surgical pain. And as you can see here in the middle, some of it have high incidence, and these represent also the estimated incidence of chronic severe pain. So in terms of incidence of chronic pain at all, either mild, moderate, or severe, amputation was the highest, followed by thoracotomy and mastectomy. And interestingly, as we mentioned, inguinal hernia as well represent high, very high risk, could reach 63% in some studies of developing chronic post-surgical pain. Also, coronary bypass grafting, cesarean section, cholecystectomy, vasectomy, and some dental surgeries. Then I have another table from British Medical Journal Education. And what caught my attention here was the breast augmentation surgery. And I found that it has an incidence of 13 to 38% of developing chronic post-surgical pain. And I was wondering if the surgeon include the possibility of this chronic post-surgical pain in their surgical consent. Also, another surgery which can include iliac crest bone harvest site, which is very, very minor procedure during another big procedure just to take a graft. It represents a risk of 30% developing chronic post-surgical pain. So in order to understand the acute to chronic pain transition, we need to go back a little bit to the basics. And as we know, there is pain receptor which can transmit signals to A delta and C fiber, which A delta is the rapid conducting myelinated fiber, and C fiber, which is a small in diameter, and it can conduct more slowly. Then all this fiber will relay in the spinal cord. Then from the spinal cord, it will go through spinothalamic and spino-reticular tract to the higher center. Then it will be projected in the cortex. So a lot of modification of pain projection happen in this level and in the higher subcortical level. And we have a lot of neurotransmitter which can modify the pain transmission. So we have glutamate, which is a major excitatory neurotransmitter, which is responsible for a phenomena, we'll talk about it later, called central sensitization. And we have the NMDA receptor agonists, which is responsible for another mechanism, which could contribute to the development of chronic post-surgical pain called wind-up. So what is the possible mechanisms of chronic post-surgical pain? Initially, everybody thought that chronic post-surgical pain happened due to nerve injury. And to be honest, there is no clear mechanism that could fully explain the chronic post-surgical pain. So we like to believe that it's nerve injury during the surgery. And then as a result of the surgery and the nerve injury, there will be some inflammatory and immune reaction, either due to the damage of the axon or due to release of inflammatory mediators in the surgical site. These act locally and can send frequent impulse to the spinal cord and cause hypersensitivity and ectopic neural activity, contribute to the central sensitization. So central sensitization occurs when repetitive, painful, or nociceptive stimuli comes to the spinal cord and result in altered dorsal horn activity and amplification of sensory flow. This can lead to some changes, permanent changes or long-term changes to the spinal cord in terms of death of inhibitory neurons. So there is inhibitory and there is excitatory neuron. And as a result of repetitive stimuli, these inhibitory neurons can be replaced by excitatory one. And these changes lead to some evoked and spontaneous symptoms associated with neuropathic pain, such as allodynia and hyperalgesia. And as we know, allodynia is having painful sensation from non-painful stimuli, and hyperalgesia exaggerating the mild painful stimuli to higher intensity painful stimuli. So typically you can find the patient complain of, he will tell you, oh, over this scar I have in my chest or over my tummy, I can't tolerate the feeling of the cloth over my scar, which will be a painful stimulus translated from non-painful stimulus, which is allodynia, and this is very common. However, the link between nerve damage during surgery and development of chronic post-surgical pain is not that easy. It's quite complicated. So not all patients with nerve damage develop chronic post-surgical pain, and those who develop chronic post-surgical pain do not necessarily have neuropathic pain. So also some operation not associated with nerve injury and can result in chronic post-surgical pain. So rather rather than concentrating in the mechanism and try to understand it, while a lot of scientists are trying to search for the causes, we better focus in the risk factor, try to recognize what factors can lead to chronic post-surgical pain in order to prevent it. So as anything in the perioperative period, we can classify it in perioperative, interoperative, and post-operative. So starting from perioperative, existing pain and the intensity of perioperative pain. For example, if a patient has a trauma and he was in lower limb pain or chronic ischemia with lower limb or upper limb pain, and then afterwards he has a surgery to have an amputation. So if this pain continued for 1 month in some studies, it showed a strong prediction of chronic post-surgical pain. Also, young age is more associated with development of chronic post-surgical pain. In some studies, they found that breast cancer surgery related chronic post-surgical pain decreased by 5% for each year increase in the patient's age. Also, female are more susceptible to chronic post-surgical pain. And there is also some genetics susceptibility in the expression of some enzyme, which is responsible for neurotransmitter expression in the dorsal horn cell. The most important from my point of view is the psychosocial factor. It has an important effect on any chronic pain, and this also includes chronic post-surgical pain. As we say, chronic pain and psychological disorder follow the shadow of each other. So chronic pain can give rise to or provoke psychological illness, and psychological illness could be presented as chronic pain as well. So also the cognitive and behavioral trait is really important factor in development of chronic post-surgical pain. So if the patient has a fear of surgery and his fear was not addressed, or there was no kind of communication to adjust the patient expectation to pain after his surgery, this could contribute to the development of chronic post-surgical pain. Also, some patients by nature have catastrophizing personality. So they are predicting pain and exaggerating their prediction to pain. Psychological construct of this person, sometimes rumination, magnification, helplessness, and he have unrealistic pain expectation after surgery, which could be alleviated by careful communication with this patient and explanation of the expected pain and the lines of treatment. Also compensation claim, and for those who work in chronic pain medicine, they know well that any patient associated with compensation claim, it may start and have the same incidence like any other chronic pain, but as long as the compensation claim continued, this contribute to the longevity of the symptoms and persistence of the symptoms later on. Next group of factors, which is intraoperative factors. For example, the longer and by implication more complicated operation are associated with more chronic pain. This may reflect the degree of tissue damage and degree of possible inflammation and also possibility of nerve injuries. Always laparoscopic surgical approach result in less chronic pain after a lot of surgeries like hernia repair and cholecystectomies in a lot of studies. Repeated surgery, for example, for hernia repair, found to have a higher incidence of moderate to severe pain intensity at 6 and 12 months in a lot of studies. Using electrocautery also may result in more chronic post-surgical pain compared with laser. Post-operative factor that could influence the development of chronic post-surgical pain, including the adjuvant interventions such as radiotherapy in cancer surgeries. Also, if there is bleeding or infection, because also this may reflect the possibility of a lot of tissue damage and nerve injury in the post-operative period. Post-traumatic stress syndrome symptoms and depression may contribute to development of chronic post-surgical pain. But the most important factor, from my point of view, is the severity of acute post-operative pain. So the severity of post-operative pain is a strong predictor of the development of chronic post-surgical pain. And also, again, this may reflect the degree of tissue damage or the individual response to pain. How the patient deal with this kind of pain? Is he catastrophizing, or is he realistic, or if he tolerates or he doesn't tolerate, if he has fear and avoidance, or he is confronting. Most important, supporting the hypothesis that repeated nociceptive stimulation during the perioperative period result in nervous system changes, such as central sensitization. So my message here to my colleague anesthetists, always don't underestimate the severity of acute postoperative pain. Pain is always what patient described, and always has plan A, P, C, even D for the management of postoperative pain, and treat this postoperative pain adequately all the time, especially in the surgeries with higher risk of developing chronic post-surgical pain. And as we say, prevention is better than cure. It's an important phrase in managing any kind of illness, but in particular here today in chronic post-surgical pain, which is really, really very difficult to treat and could be prevented by some simple measures that we can employ during our anesthetic techniques. So chronic post-surgical pain preventive techniques can be applied in perioperative time, and it could be perioperative analgesia, psychosocial factors, or surgical factors. But to be honest, currently there is no definitive way to prevent the occurrence of chronic post-surgical pain. It's, as I mentioned, it's still relatively new era of researches, and still there is no definite answer for a lot of questions. And there is various technique has been tried by anesthesiologists and surgeons to reduce the risk with variable success. So starting with perioperative analgesia, considering the pathophysiologic mechanism proposed to contribute to chronic pain, it would seem logic that a good perioperative pain control should have a long-term benefit by reducing central sensitization. And before we start talking about the measures that can be employed, we need to say more definitions here about perioperative analgesia. So we always hear about preemptive and preventive analgesia. So preemptive analgesia, by definition, is an analgesia that is delivered prior to skin incision. Here in surgery, we can say analgesia that delivered before the noxious stimulus, and the noxious stimulus here is the skin incision in the chronic post-surgical pain. So preemptive epidural analgesia has found to be having significant benefit in post-operative pain as an acute post-operative pain, but we will talk if it have any benefit for chronic post-surgical pain as well. Benefits of other type of preemptive analgesia is, to be honest, not so clear yet. What about the preventive analgesia? So preventive analgesia described as an analgesic treatment that outlasts its expected duration, and it may be important to minimize chronic post-surgical pain. So, in a nutshell, preemptive analgesia is beneficial in prevention of acute post-surgical pain. But preventive analgesia is to minimize the incidence of chronic post-surgical pain through a reduction in central sensitization. And to be effective in preventing sensitization of the nervous system, it should act over the period of time during which there is an inflammatory stimulus. So it should start in the perioperative period and continue with the patient as long as there is a source of pain. Also in the post-operative period. So the adoption of preventive analgesia technique rather than preemptive has shown benefits to prevent chronic post-surgical pain. So also multimodal analgesia as a term, we used to hear it a lot, and a lot of us use it for acute pain. So the presence of pain before surgery and the severity and duration of acute post-operative pain are predictor of chronic post-surgical pain, as mentioned, because it leads to spinal sensitization. Following trauma, also it may transform acute pain to chronic pain. So this can be prevented by aggressive treatment of acute pain. Therefore, a good perioperative pain management is thought to prevent the occurrence of chronic post-surgical pain. And adopting multimodal approach to treat pain is a good way to treat pain effectively with no risk of overdosage and subsequently risk of toxicity from a single agent. Back to our pain pathway, as we mentioned, we have here the nerve receptor, the nerve fibers, and the spinal cord, then the ascending tracts, the subcortical centers and cortical center. So this is where our drug or pain medication should work. So here in the level of the receptor, we can use local anesthetic infiltration, we can use paracetamol, we can use non-steroids, and in the nerve fibers, we can use local anesthetic via peripheral nerve catheter. Also, in the spine and the level of spinal cord, we can use local anesthetic, opioid, alpha agonist like clonidine and dexmedetomidine. We have also an MDA antagonist like ketamine and also non-steroids. In the higher centers or the higher level of cortical centers, we have opioid, alpha agonist, paracetamol, and also an MDA antagonist. This is what we call multimodal analgesia. So a lot of anesthetists now are shifting their practice from a single strong agent to multiple agent. Give paracetamol intraoperatively, give non-steroids if available, clonidine, magnesium, IV, lignocaine. So this is in order to reduce the heavily reliance on opiates in post-operative period. This improved the outcome, and also it found to be contributing to the prevention of chronic post-surgical pain. So in terms of preventive analgesia or analgesias that have shown some evidence for the prevention of development of chronic post-surgical pain, so far we have regional anesthesia, we have the ketamine, we have the Gaba Ventinoid, antidepressant, and intravenous lignocaine. So starting with regional anesthesia, it may be possible to prevent nociceptive input into the dorsal horn. This is the key mechanism here. If you prevent these noxious stimulus from reaching the dorsal horn, you will prevent the central sensitization. And there was a Cochrane review in 2013 found epidural analgesia for thoracotomy to be beneficial in reducing the risk of chronic post-surgical pain at 6 months, and for also paravertebral block in reducing chronic post-surgical pain following breast surgery for breast cancer at 5 and 6 months. This is the systematic review, which was published in 2013 in BGA. So it's about regional anesthesia to prevent chronic pain after surgery. Also, in terms of regional anesthesia, they found in some studies that spinal anesthesia has also been shown to be beneficial relative to general anesthesia in reducing the risk of chronic pain after cesarean section. Another one more benefit for the regional anesthesia over general anesthesia in cesarean section. Also, perioperative epidural analgesia was found to reduce the incidence of severe phantom limb pain. In this interesting study by Karnikolos and his colleague, they have 65 patients who underwent lower limb amputation, and they use different protocols for pain management in pre, intraoperative, and post-operative. So they compare patients who have preoperative epidural, intraoperative epidural, and post-operative epidural to others who have mix of epidural and PCA, and for those who never had an epidural before. And they found the incidence of chronic post-surgical pain using different pain scales in their patients is much, much lower. Notice that line in red for patient who has epidural pre, inter, and post-operative compared with other modalities of pain control for other patients. And they found to have much less pain after 6 months of their surgery. Also, this is non-randomized study by Borghi et al. Examined the perioperative percutaneous insertion of peripheral nerve catheter for the post-operative infusion of local anesthetic following limb amputation. Interestingly, they used this local anesthetic catheter infusion for 30 days. And they found that this incidence of phantom limb pain after 12 months was 16% only, which is much, much less than the other studies. But the problem is, I don't think that every hospital and every department will be able to use a local anesthetic infusion catheter or wound catheter for 30 days. It's one of the limitations of this application of this study. This study also showed that the infiltration of local anesthetic following removal of an iliac crest bone graft lead to lower iliac bone chronic pain after 4 years of follow-up. Remember, we said the iliac bone graft donor site is one of the sites which has high incidence of chronic post-surgical pain, which was 30%. So in essence, local anesthetic and regional block can significantly reduce the chronic post-surgical pain incidence. And rather than having this patient in the pain clinic for years and do much harm for him in terms of dependence on pain medication, spending time in the pain clinics and a lot of pain procedure, it would be much better if we will have kind of regional block for any surgery that could be liable for chronic post-surgical pain. It's like, think about it, if patient comes for inguinal hernia, it would be much easier to stick a needle in his groin and inject some local anesthetic and minimize the incidence of chronic post-surgical pain, which is a very simple procedure. Any patient for thoracotomy should have kind of regional anesthesia. Heavy reliance in opioid may not be adequate, may not be good for post-operative period in terms of respiratory function and a lot of things. And also, it doesn't minimize effectively the incidence of chronic post-surgical pain. So think about regional all the time. Whenever you can, stick a needle in the patient, either around the nerve, neuroaxial, or local wound infiltration. This will save a lot of time and effort to treat chronic post-surgical pain. The second drug in our list is ketamine, and it's another revive of an old-fashioned drugs, which was like about to be going extinct, then was revived by its, a lot of anesthetists started to use it again for many reasons. One of the reasons that I think ketamine has booked his place again in our trolley is because his effect in chronic and acute post-surgical pain. So as we know, ketamine is an MDA receptor antagonist, and it's rarely used as a sole anesthetic due to psychosomatic, but it can be very useful adjuvant to drug in patients requiring high level of opioid. So it prevents an MDA receptor mediated wind up. You remember we mentioned two mechanisms in chronic post-surgical pain. Was one central sensitization and the other one was wind up. So wind up is prevented by effectively by ketamine. A lot of anesthetists are using it now for pain control, and the suggested dose by a lot of studies is 0.2 to 0.5 milligram per kg as a bolus. And some other studies suggested also it can be given as infusion afterwards, 2 to 5 microgram per kg per minute in opioid naive patient, and it significantly reduced the requirement of opioid in post-surgical time, and it also reduced the risk of opioid hyperalgesia. There is also some strong data that perioperative NMDA receptor antagonists like ketamine show preventive analgesic effects, and this is thought to be due to their action in preventing wind up and central sensitization. In this study, or in this Cochrane review, there was 17 studies. They analyzed the results of using ketamine by intravenous infusion on prevention of chronic post-surgical pain after 3 and 6 months, and they found it is 25% and 30% less, respectively, after 3 and 6 months. And in this, they recommended intravenous bolus dose slightly higher than the old recommended one. So they used 2 to 7 milligram per kg as a bolus, and they used infusion of 2 to 7 microgram per kg per minute for prevention of chronic post-surgical pain. And the interesting thing is they found that adverse event rate were similar between ketamine and placebo group. The next group of drug is Gaba Ventinoid. So Gaba Ventinoid was initially introduced as an anticonvulsant in 1990s. And subsequently, trials show it is to be beneficial in the treatment of neuropathic pain. And they found that it acts in some subunits of calcium channel, and it inhibits calcium influx and subsequently release of excitatory neurotransmitter in the pain pathway. It started with gabapentin, then pregabalin was discovered, which is structurally similar to gabapentin, and it was thought to have greater analgesic potency and more favorable pharmacokinetic profile in relation to gabaventinoid. But I think this view is rapidly changing. So in this meta-analysis, they studied the prevention of chronic post-surgical pain using gabapentin and pregabalin. And they included 11 trials, 8 studies used gabapentin and the other used pregabalin. And they reached to a conclusion that the results support the role of Gaba Ventinoid in prevention of chronic post-surgical pain. And they suggested that there was difference between the protocols which was used during the perioperative period. Some people used very high doses, which is 600 and 1200 per day. Some people started it in the operative day or pre-operative or post-operative. So there was a lot of variation in the protocol. So they are suggesting a trial which can use a standard treatment protocol and search the results appropriately. Despite that results of this study, which was published in 2012, there was another meta-analysis of randomized trial, which studied 18 randomized controls trial, was published and unpublished results, and it couldn't find any reduction of chronic post-surgical pain at 3 months after using pregabalin. This was regarding the pregabalin, but I think gabapentin still have its place as a preventive measure for chronic post-surgical pain based on the previous meta-analysis. The next group of drug is antidepressant, and all of us know amitriptyline, fluoxetine, duloxetine, venlafaxine as psychotic drugs which can be used for neuropathic pain. It has also some roles for prevention of chronic post-surgical pain, but it's not yet so clear. For example, we have this study by Wong and his colleague, and they tried to review the use of antidepressant for the prevention of chronic post-surgical pain. And they found they studied the venlafaxine, duloxetine, and escitalopram, and they have positive outcome with only venlafaxine. In one of the study, it compared the venlafaxine to the effect of gabapentin, and it found that it's equally effective in prevention of chronic post-surgical pain as gabapentinoid. The last but not least is the intravenous lignocaine. I know a lot of people loves intraoperative intravenous lignocaine, either bolus or infusion. So there is a meta-analysis of intraoperative IV lignocaine found reduction in acute post-operative pain with those undergoing abdominal surgery. So IV lignocaine has also been found to have anti-hyperalgesic effect that lasts for days after surgery. And remember, we said the acute post-surgical pain contribute to the development of chronic post-surgical pain. So if a drug can prevent or affect reduction of acute post-surgical pain for a couple or 3 days after surgery, it would help in prevention of chronic post-surgical pain. We presume that. So the mechanism of action is not fully understood, and it can't explain fully by its sodium channel blocking effect. However, a lot of findings suggest that lignocaine may have a role in preventing central sensitization, and hence its prevention of chronic post-surgical pain. So this study or meta-analysis of some trials show perioperative lignocaine infusion was effective in prevention of chronic post-surgical pain. And for those who likes intravenous lignocaine, I have found these guidelines, which was published in 2021 about the use of intravenous lidocaine for post-operative pain and recovery. It's international consensus statement on the efficacy and safety, and some protocols are there. So it's nice paper if you would like to have a look. Drugs that is suggested to help reducing the risk of chronic post-surgical pain, but still there is no enough studies to support this suggestion. We have non-steroids and acetaminophen. There is no studies that could prove the effect of those two in chronic post-surgical pain, but we presume that it controls the pain in the perioperative period in general. And remember the role, prevention of acute post-surgical pain can contribute to the prevention of chronic post-surgical pain. Also opioid, but remember, heavy reliance on opioid alone may not be sufficient. Alpha-2 agonists like clonidine and dexmedetomidine has promising results that still needs to be confirmed. Steroids, we know that steroids is frequently used for chronic pain procedure, but there is no enough data to support the use of systemic steroid for prevention of acute and chronic post-surgical pain, so cannot be recommended. The next bundle for management of chronic or prevention of post-surgical pain is to tackle the psychosocial factor, and it's like I would say it's one of the duties of the surgical and anesthetic team to tackle these or address these issues with the patient in the peri-operative period. All of us knows, and especially who are interested in chronic pain management, that pain perception is influenced by mood, memory, expectation, and social environment. So psychosocial factors should be considered alongside the pain assessment and management using pharmacologic and non-pharmacologic agents. And I always like to highlight this diagram. It showed here, like, if patient has an injury, he will have painful experience, and we will have two kinds of person. A person who has a catastrophization personality leads to fear and avoidance, and this will lead to disuse and disability and depression, and this will lead to more painful experience, and he will be in vicious circle. Other personality, he will have no fear and he will have confrontation, so he'll have proper recovery. So it's up to us to help the patient to be in this side or to go to this side. We should pay attention to the preemptive cognitive and behavioral intervention that we can employ in the perioperative period to help the patient to overcome his fears of pain after in the post-operative period, and also encourage a more positive attitude to pain relief, and where possible we should try to involve patient in their pain management strategy. If he have a previous surgery similar to the surgery he will have today, it's good to ask him what type of pain management he have last time, and was he happy with this pain management? Was it adequate or not? This will help a lot, and this is what we call involve the patient in his pain management. Also, social relationship, like we say, balanced social relationship is mandatory to overcome pain at any time, and this includes an acute post-surgical point. So it's like some studies for chronic pain showed that when partner is present who is attentive and likely to help them to avoid activities that may exacerbate pain, then a patient is likely to report more pain and underperformance on tasks. So things should be balanced. Social relationship should not be overprotective or should not be kind of ignoring the patient needs, and should be something in between. As we say, like we can see a woman, if a woman or a man, his spouse is so protective and around all the time and trying to protect him and try to be his advocate in expressing his pain and ask for analgesia for him, the more likely the patient will report pain. And again, at the end, we should be managing the expectation and give the patient realistic view of his post-operative period and our plans of his pain management. And by addressing these issues in the perioperative period, it may be that we can also reduce the progression to persistent pain and disability in those who are at risk. The last factor is the surgical factors. So always we should revise the indication of surgery. As we see in breast augmentation surgeries, there is high risk of chronic post-surgical pain. So patients should be aware of that. And he should choose based on like possibility if he can accept that or not. Also, the surgical technique is recognized as a risk factor in chronic post-surgical pain. And as we mentioned, so here some studies showed us, for example, this study in Germany, it was studying the influence of preservative versus division of ilioinguinal, iliohypogastric, and genital nerve during open mesh herniorrhaphy, and it found high incidence of chronic post-surgical pain if the nerve was not identified or if it was identified and divided versus if it was identified and avoided. Also, this surgery showed that laparoscopic surgery may reduce the risk of intraoperative nerve damage, and this Cochrane study involving 41 published reports of eligible trial involving more than 7,000 participants found that there was less persistent pain and numbness following the laparoscopic repair. So another example, women who had breast surgeries in breast cancer center where there is highly trained to anesthetize and to operate on those patients was found to have less incidence of developing chronic post-surgical pain after breast cancer surgery. In general, minimal invasive surgery and less extensive technique was found to be associated with this incidence of chronic post-surgical pain. This is the preventive measures, which we mentioned that it's very, very important, more important than treatment, because treatment could be devastating, could be long, and patient could stay in chronic post-surgical pain even up to 5 and 10 years. So if the chronic post-surgical pain after all these preventive measures we employed come for the chronic pain surface for treatment, the treatment can be ranging between simple analgesic up to interventional approach, such as targeted specific injection and neurostimulation even in some cases. And early psychologic treatment is really recommended in those category of patients. So just to summarize our talk today, to summarize our approach to patient who is in risk of developing chronic post-surgical pain, we should always ask ourselves, does the patient have perioperative pain? Is your patient having chronic ischemia waiting amputation, or is he a trauma patient who's in pain and still under evaluation for surgery? So if he is in pain, consider active pain management. And it's really recommended, if you could reach out to the surgical teams in your hospital, start to make protocol for those who are waiting amputation, for example, because they are at very high risk of chronic post-surgical pain, and advise them if they can refer the patient who are waiting for assessment for amputation. If they are in pain, if you can start active pain treatment before surgery, use BCA, neuroaxial analgesia, or peripheral nerve block. Then also ask yourself, does the patient have perioperative risk factor for developing chronic post-surgical pain? And we also know from the previous slides that female, young patient, and some genetic predisposed patient, and some patient who have psychosocial factor or pre-existing chronic pain could be at higher risk of developing chronic post-surgical pain. So you should offer pre-operative counseling and plan for your surgery and your preventive analgesic measure that you will use during and after the surgery. Also ask yourself, does the surgery have a higher risk of developing chronic post-surgical pain? We mentioned breast surgeries, thoracotomies, amputation, inguinal hernia, breast augmentation, and so on. So if you are anesthetizing a patient for those surgeries, consider alternative procedure if can be, and alternative techniques, like if, for example, rather than laparotomy, use laparoscopy as an example. Also try to ask your surgeon if he can avoid nerve injuries. Also from your side, you should use active preventive measures like regional multimodal analgesia, Gaba Ventinoid, Lignocaine, and ketamine. In one of the hospital I worked in a few months ago, for any thoracotomy patient, always he will have kind of regional, either epidural, rectospinal, what is the kind of surgery, even if it is VATS, still he needs to have any kind of regional anesthesia. Also, if he is admitted to the hospital one day before, they normally start Gaba Ventinoid on him. This is from surgical side, not even from the anesthetic side, for prevention of chronic post-surgical pain. Also in breast surgeries, consider effective regional anesthesia. If you can do Biggs block or rectospinal or whatever you can do, just stick a needle and give some local anesthesia to prevent a lot of troubles afterward. So after surgery, if acute post-surgical pain not adequately controlled, consider recognizing the cause. If it is infection or hematoma or whatever, if you excluded other reasons, consider effective post-operative pain management. Change your pain protocol you are using for this patient. If you need to do a rescue block for him, don't hesitate. Also, you can use BCA, multimodal analgesia, and regional block when needed. So the take-home message is here that chronic post-surgical pain is a reality, and it makes significant contribution to the burden of chronic pain services. Perioperative pain contribute to central sensitization and subsequent chronic post-surgical pain. Regional anesthesia techniques reduce the risk of chronic post-surgical pain in many surgeries, and you can give adjuvant analgesic during the surgery. Some people give ketamine, IV lignocaine, magnesium sulfate, clonidine, anything that could help you prevent or reduce the severity of acute post-surgical pain may ultimately contribute to the reduction of chronic post-surgical pain. I hope I give you a message that can be, as Joe mentioned in the beginning of the lecture, could motivate you to have a minor or major changes to your practice towards preventive analgesia for chronic post-surgical pain. And thank you very much for the audience, the faculty, and for Joe and Dr. Ranjit. Thank you.
Thank you very much, Dr. Ahmed. I think from my point of view, the take-home message, prevention is always easier to treatment. Before doing any surgery, if you think that given any kind of regional anesthesia or local anesthesia will delay the surgery, think about the patient. 3 or 6 months later, suffering, going to the pain clinic. We should always keep that in mind. And thanks, Dr. Ahmed, for reminding us with this essential part of our duties as anesthetists is post-operative chronic pain that we can actually, from your lecture, we can easily and significantly reduce by doing very simple measures. And I think it's available in most of the hospitals in any country. We have a few questions. Mohammed Suleiman.
Sorry, I'm just sorry for interruption because it's my area of interest, and I'm one of the group searching for chronic post-surgical pain. So first, I want to thank, sorry for interruption, Dr. Yusuf. I want to thank Dr. Ahmed for make everything very simple. It is not simple like this, but make it,
no, it is not
very simple. I like it. But from a research point of view, there is nothing agreement about chronic post-surgical pain, even the name. Some people give chronic post-operative pain. Some people just continuous post-operative pain. Even the definition, nothing about the definition agreed. And also for the drug, meta-analysis you speak about is a lot of bias in it. So it is a disease specific. So in TKA, Gaba Ventinoid is very effective, but in other diseases, not effective. So it is a procedure related. This is the first one. Second thing about the problem of persistent post-operative pain. Now I want to kiss your hand because you sent a message for our colleague, because really we're suffering a lot, not just the patient. For my clinic, at least I get about 20 to 30% of people because we don't treat a patient in the right way, at least from anesthesia side. So the most important thing is that multimodal analgesia to care about, because don't think that immediate post-operative pain only. And there is a new study showing that every 10 minutes increase in the severity of pain increases 30% of chronic persistent or post-operative pain. And the complication of this problem, and I think Dr. Ahmed knows that from the pain clinic, it can come from quality of life to suicide tendency. Many people just, there is a people commit suicide because of this such a problem. And also, there is no relationship still in the study. Dr. Ahmed speak about age, blood transfusion, and sex. It is maybe positive in some study, not positive in some other study, because we are still in the childhood of this research. But as Ahmed said, because the last survey from American Beam Society, 2012, 2015, and 2020, because don't have a solid evidence, and this survey joined about 300 or more from the pain clinician or just people working in pain. And all the time, if you don't have a solid evidence to go for, the opinion of expertise said that the most important thing is the aggressive multimodal analgesia and the preventive analgesia away from the preemptive. And second thing, to treat the psychological issue. And I remember in one hospital, we have what's called a psychological consultant. He just all the time went for the patient. He imitating as he's a nurse, arranging the flower and asking the patient, open a talk with the patient, asking him, who's doing the operation for you? He tell such a doctor, whatever the doctor tell, oh my God, this is the best doctor here in hospital. He makes thousands of cases and no complication at all. And he agreed to make operation for you because he's very busy. And this is have a very good implication for the patient, also for psychological state. So thank you, Dr. Ahmed, and for this very simple, and I hope the message to send a message. But I want to ask you about one question only.
Yes.
What is the percentage of people you see in your pain clinic from this chronic post-surgical pain? What is the percentage?
Actually, we don't have a clear consensus, but as you mentioned, it's a lot. It could reach 30, 40%, something like that. But the figure I have mentioned in the beginning of the lecture is derived from one of the studies. It's, as you mentioned, thank you for your comment. I would like to say first, and as you mentioned, we are still very crawling in this field, and the field is open for everybody to contribute in research in chronic post-surgical pain, trying to understand and to prevent as much as we can. And as you mentioned, there is no clear cut-offs that this does and this doesn't. There is some studies here, some studies there about the effect of this drug in this kind of surgeries, and there is not enough data in the same drug in another kind of surgeries. So I think every anesthetist in every research center around the world is invited to contribute. It doesn't matter, or it doesn't affect or it is not related to chronic pain surface only, but every anesthetist should pay attention to some preventive measure during the surgery. The figure is in my service because I work in pediatric hospital at the moment for my rotation. So in my previous hospital where I work in pain clinic, it was a lot, but we don't have clear figures to answer your question. The interesting thing in your talk about the psychologist who is approaching the patient as a nurse, I was really asking myself, if you, from your point of view, was he successful in alleviating the acute post-surgical pain at least, or if you have any, or if he from his side has any data to suggest that he has, or this technique has an effect on the outcome of chronic post-surgical pain, because I don't know, like I think in many countries it's not accepted that anybody can approach a patient and introduce himself as somebody else, because in many countries this is not accepted. But if it have an impact on the results, this could be employed by different ways in different hospitals, not necessarily by the same way, pretending that you're somebody else, as I mentioned, because it could lead to legal consequences in some other countries. But I really appreciate what he does and his trial to help the patient in your hospital.
Sorry, Dr. Ahmed, it's not my hospital. It's another way working place for research. It's do research and it's not introducing the self for the patient. Just going to arrange the flowers and to open a talk to the patient. And she have a very good implication up till now, but we still, as I told you, in the early stage to collecting the data.
Okay, sorry, I just misunderstood.
Yeah, thank you very much.
Thanks.
Thank you.
Thanks.
Thank you.
Hey, thank you, Dr. Reda. We just have a few minutes left for this presentation. If you just, Dr. Ahmed, go through this question quickly. From Mohammed Suleiman, which do you prefer, clonidine or dexamethasone?
I personally use clonidine. Like it's not the common practice in maybe you know that, Yusuf. It's not common practice in Ireland, and most of us use clonidine, and it has a lot of data to prove that it's effective in acute post-surgical pain, and it has opioid sparing effect as well, but there is no evidence yet that it could be beneficial in chronic post-surgical pain.
Okay, from your experience, Dr. Ahmed, do you think clonidine is safe for day case surgeries for post-operative patients?
Well, I don't think there is any. I'm not aware of any guidelines or any studies that it could say it's not safe. We use it in my current practice, and I used it in some other hospital before in day cases, and I saw a lot of anesthetic consultant. If you use a small dose of 1 mic per kg, not in every single patient, a lot of day cases now are expanding to include more complicated surgeries, like lap cholecystectomy. In the past, patients should stay in the hospital, but now it's a day surgery. Also, inguinal hernia, which has high risk of pain in the post-operative period. So we give them clonidine, actually, and I'm not aware of anything that can go against that.
All right, okay. Second question about local wound infiltration. What's the best area, subcutaneous, dermal, or epidermal?
Subcutaneous, dermal, or epidermal? Well, I think, if you are taking bone harvesting, harvesting bone from an iliac crest, I always still ask the surgeon to infiltrate around the periosteum and deepen the tissue. But I don't think any infiltration in the skin would help in this occasion. And also injecting the nerve, the local anesthetic into the muscle. It could have, a recent studies showed that it have myotoxic effect. So I would always recommend it subcutaneous and in infiltration deep in the periosteum if the bone surgery was operated.
Do you recommend to have a course of communication skills and perioperative patient psychology? Allow me to rephrase this in another way. Do you suggest information leaflets or direct communication for preoperative post-surgical chronic pain orientation?
Well, Joe, this is a very good question, actually. What I would say, like any kind of communication with the patient to deliver the information regarding his expected pain and chronic and post-operative pain would be helpful. If you are working in a center which operates high volume of a specific patient, like if you are working in a cardiothoracic center where you have a lot of thoracotomy patient, there is no harm to prepare a leaflet, but you should choose to which kind of patient are you going to give this leaflet. Because at the end of the day, what you need is to make the information clear to the patient. Some patients will not understand from the leaflet. There is no harm to give leaflet, but also before the surgery, you need to apply kind of verbal communication with the patient, at least to make sure that the patient got the message you want to give to him. It's not only give him leaflet, then what if he didn't read? For us, if you have a leaflet from any seller of anything, I don't think you are going through the leaflets carefully. Sometimes you miss important information. So giving leaflets and having some programs sometimes to prepare the patient for the post-operative period and rehabilitation, communicate with the patient yourself as anesthetist. And I think the majority of the audience in this webinar are anesthetists. It's not visible to arrange kind of leaflets. It's normally the surgeons who are looking after this part of communication. But from your side, make sure that whatever the kind of communication was used with your patient in the perioperative period, just make sure that he got the message. This is what I want to say.
Okay, I will just take only one last question from
Joe. Joe, is this a question from
Mohammed
Al-Khatib? Dr. Muhammad Al-Khatib, he wants to talk. Dr. Muhammad? Dr. Khatib? Is he here? He can talk, Dr. Muhammad Al-Khatib? No, okay, you go ahead, Joe, Doctor.
Okay, so we'll take only one last question from Muhammad Salim. Local steroids have a rule. I think he's asking, is local steroids like dexamethasone have a rule in CVSP? And also he's asking about magnesium intravenous, which is common in Ireland as well, as intraoperative and sometimes post-operative pain control. Off you go.
Yeah, so there was no data about magnesium sulfate usage. As you noticed at the end of my lecture, there is some drugs which has some accepted level of evidence. I wouldn't say it's convincing level of evidence as me during the lecture, and as we discussed after the lecture, that it's not clear-cut evidence, but there is some drugs which have some accepted level of evidence. Some drugs showed evidence in prevention of acute post-surgical pain. And as we mentioned, prevention of acute post-surgical pain in itself could help in prevention of chronic post-surgical pain. Clonidine is one of it. Opioid is one of it. But think about opioid. For example, patient after cardiac surgery, chronic coronary bypass grafting, they have significant percentage of developing chronic post-surgical pain, and they are flooded with opioid in the post-operative period. It helped to relieve acute post-surgical pain, but still it doesn't do anything for chronic post-surgical pain. Magnesium sulfate is one of the drugs that it showed effect to reduce opioid sparing effect, reduce opioid hyperalgesia, reduce requirement of opioid in the post-operative period. This is all well established, but it has no clear role in prevention of chronic post-surgical pain yet. It could have been, but there is no evidence. Okay. What was the other part of the question, sorry?
It was about steroids and magnesium sulfate. I think.
So answer the part of magnesium. I hope this answers your question.
Yeah,
regarding the steroids, we used to use a steroid injection in the surgical side with variable success rate. So it's described in the treatment, and it's one of the lines of the treatment is to inject steroid either around the nerve or in the area of the pain. We do that, and some patients show good response, not persistent. Some of them will have pain relief for 6 weeks, up to 6 months, and still they come back at the end of the day. Some of them doesn't have any response at all. And as I mentioned, in some centers, not the same center I work in, at the end, when they fail to relieve their pain by all of the recognized measure, they go for neuromodulation and sometimes spinal cord stimulator insertion.
And the last question, I think you already answered.
I'm okay to get more.
No, just because of the time, that's the last question. I think you answered. The CPSP is a result of actual nerve injury damage, keloid formation, local traction, or distension. I think you mentioned that it's a mix of all of these, depending on the type of the surgery. I think that's it. I apologize if we did not answer more questions for the sake of our time, and I will leave the mic to Dr. Saad. Thank you so much, Dr. Ahmed and Dr. Ranajeet, for this informative lectures. We've learned a lot this night, and I hope the same for our attendees. Thank you so much.
Certainly, Joe, we learned a lot tonight, especially with Dr. Ranajeet about the helmet non-invasive ventilation. It is a new issue, and the pain lecture with Dr. Ahmed Abbas. But just as regards the education and the communication with the pain lecture, because myself I'm involved in the cancer list every week, and I see all of those patients in the pre-operative assessment clinic, and I don't use time to explain all of those blocks and the regional anesthesia to every single patient. As you mentioned, that we give them the leaflet, but alternatively, we take the nurse from the pre-operative assessment to join us in the perioperative time in theater, and we show her how we do the block, and how we do the regional anesthesia, how we do the paravertebral block, Bixia blocks, and the tab block, and later on, this nurse is going in the pre-operative assessment clinic, and she talked to the patient one-to-one, and explained to him how the doctor does the block and what is the side effect, and what do you expect from this regional anesthesia, and how it's going to affect your pain relief afterward. And that is the matter of number one, education. Number two, communication. Number three, the nurse has much more time to explain to the patient the advantage and disadvantage and all of this in a time and a comfortable fashion. Tonight we are very, very successful. Especially we have being surrounded by the top panelists in anesthesia and intensive care, Professor Saham Marzouk, Professor Nabir Askalani. He's the president of the Egyptian Society of Anesthesiology. Dr. Yasser Reza, he is one of the pioneers in interventional pain medicine, Dr. Hoda Fauzi, Dr. Hazim Yassin, and all our colleagues. I wanted to share with you only one thing here. Just if you let me do it. Okay. Next week we have top panelists and speakers from everywhere. And you see here we have next week. This time we have Prof. John Doyle, who's going to speak to us about history of anesthesia, which is absolutely fascinating topic. And the other star is Professor Abdulazim Al-Dawlatli. He's the chief of Saudi Journal of Anesthesiology, and he's a professor of anesthesiology in Riyadh. Professor Dawlatli will talk to us about a very hot topic, update in thoracic anesthesia. I'm looking forward to see all of you next week in the presence of the chairman of that session, our iconic star from Acute University, and he's working at the moment as a consultant of the neuroanesthesia, Professor Assam Manna. I'm looking forward to see all of you next week, and thank you very much for tonight's session. Dr. Ranajeet from India, Dr. Ahmed Abbas from Dublin, and Dr. Joe Awad from Dublin. Thank you so much, and from me and from the other people, and thank you.